Good afternoon, everyone. So my next video is on the topic broad spectrum antibiotic, that is chloramphenicol. And now I'm going to discuss with you the chloramphenicol. And before I start my video, I want to request you, if this video is useful to you and if it is helpful to you, kindly subscribe to my YouTube channel, that is Dr. Nitika Hans Pharmacology Discussion. Now I'm going to start the video on chloramphenicol, that is broad spectrum antibiotics. Chloramphenicol was initially obtained from Streptomyces venezuelae in 1947. It was soon synthesized chemically, and the commercial product now is all synthetic. This it was initially obtained from Streptomyces venezuelae, and it was synthesized chemically, and the commercial product now is all synthetic. Introduction: it is the broad spectrum antibiotic. It acts against aerobic, anaerobic gram-positive bacteria, gram-positive bacteria, gram-negative bacteria, rickettsia. It is bacteriostatic in nature, and it inhibits the growth of the bacteria, and it is bactericidal, means it kills the bacteria in high doses, that is, it acts against Haemophilus influenzae, Neisseria meningitis in the high doses. And mechanism of action is that chloramphenicol attaches to the 50S ribosome near the receptor site and prevents peptide bond formation between the newly attached amino acid and the nascent peptide chain. Because it attaches to the 50S ribosome near the receptor site and prevents the peptide bond formation between the newly attached amino acid and the nascent peptide chain. Means on the peptidal side there is amino acid chain is there, and the newer tRNA attaches to the receptor site, and the bond between the amino acid of the peptidal chain and the receptor site does not form, because the peptide bond does not form. So protein synthesis inhibitor, it inhibits the peptidal transferase enzyme. And a mechanism of action of tetracyclines is that it attaches to the 30S ribosome of the amino acid tRNA, means the attachment of 30S attachment of the amino acid tRNA to receptor site of the mRNA ribosome complex is stopped, so protein synthesis doesn't take place. It is like this: amino acid, it binds to the receptor site, and then the peptide bond formation takes place between the peptidyl side amino acid and amino acid on the receptor site, and then transpeptidation takes place, and tRNA leaves the P site. Then the translocation process takes place. Like this amino acid attaches to the peptidyl site, and then this chain, it gets freed. It gets attached to the receptor site, and then tRNA is removed. This is how the protein synthesis takes place. And this transpeptidation process is inhibited by the chloramphenicol. It inhibits the formation of peptide bond formation. That is, translocation from A site to P site does not occur, and protein synthesis is inhibited. Binds reversibly to 50S, inhibits peptidal transferase, protein synthesis is inhibited. Inhibits the transfer of elongating peptide chain to newly attached amino acid tRNA at A site. Antimicrobial spectrum is that it is similar to the tetracyclines, and it is basically bacteriostatic in nature, but at higher concentrations, it is bactericidal to Haemophilus influenzae and Neisseria meningitis. It is active against Haemophilus influenzae, Bacillus pertussis, Klebsiella, Neisseria meningitis. And like tetracyclines, is ineffective against mycobacteria, Pseudomonas, Proteus, and viruses and fungi. And it is available in two forms: chloramphenicol palmitate, which is oral, and chloramphenicol succinate, which is parenteral. Through oral route, it is completely and rapidly absorbed. Dose is 50 to 100 milligram per kg per day. It is widely distributed in tissues and body fluids in CSF, and it is metabolized by glucuronide conjugation. It is eliminated in urine, bile, and feces. 1 to 10 milligram per ml inhibits the gram-positive bacteria, and 0.2 to 5 milligram per ml inhibits the gram-negative bacteria. And resistance develops by the when it is broken down by acetyl transferase enzyme chloramphenicol. Then its resistance develops, or there is decreased permeability into the bacterial cells of the chloramphenicol that can lead to resistance of the chloramphenicol by the acetyl transferase enzyme, which acts on the chloramphenicol and it breaks down the chloramphenicol, and or there is reduced permeability into the bacterial cells. Cross-resistance seen between chloramphenicol, macrolides, and lincosamides like clindamycin, quintistrine. Cross-resistance can be there. Means if it is resistant to chloramphenicol, then the patient is also resistant to macrolides and lincosamide. Therapeutic uses is that its clinical uses is now highly restricted because of its ineffectiveness, plus it is higher toxicity, fatal toxicity, and it may be combined with any other drug combined for internal use banned in India. But it may not be combined. It is never combined. It is ineffective in nature. It is very highly toxic, and now it is banned to be used in the country. And ceftriaxone and vancomycin are presently the first-line drugs for the bacterial meningitis. And second-line drug is it is the chloramphenicol is the second-line drug for Haemophilus influenzae. And is also being used in the treatment of intraocular infections systemically. It is given, attains higher concentration in ocular fluid. It is preferred drug for endophthalmitis caused by sensitive bacteria. And it can be used in conjunctivitis, external ear infections, 0.5 to 5%. That is highly effective. And it can be used on skin and other areas is not recommended because of the risk of sensitization. Means it is having high risk of sensitization, which is not used on the skin and other areas of the body. Clinical uses, it is basically it was firstly used for the Salmonella typhi. It is effective against the Salmonella typhi. It was a drug of choice for typhoid, enteric fever, UTI, pyogenic meningitis, anaerobic infections, typhus, Rocky Mountain spotty fever, meningococcal meningitis. It can be used in treatment of these diseases. Topically, it can be used for eye infections also, for conjunctivitis, for endophthalmitis, and ear infections also. When chloramphenicol should not be prescribed, that is in hepatic failure in newborns, less than 1 week, or in premature infants. This is not given. Adverse effects are, it can cause nausea, vomiting, diarrhea, oral and vaginal candidiasis, bone marrow disturbances, that is, it leads to suppression of bone marrow, irreversible suppression of RBCs can occur, aplastic anemia, irreversible or prolonged use, aplastic anemia can occur, and it can lead to gray baby syndrome. Bone marrow depression, idiosyncratic reaction, 1 in 30,000 to 40,000. It is the rare case. In rare case, bone marrow depression can occur. Aplastic anemia, granulocytosis, thrombocytopenia, pancytopenia, unpredictable but serious, often fatal. Dose dependent is it can result in anemia, leukopenia, thrombocytopenia, and it is reversible on stopping the drug due to inhibition of mammalian mitochondrial protein synthesis. It can lead to anemia, thrombocytopenia, and leukopenia. Gray baby syndrome, it can be occurred in high doses when given prophylactically to neonates, especially premature. And in this, the baby presents with stopped feeding, vomiting, hypotonic, hypothermic, abdominal distension, respiration becomes irregular, and there is ashen gray cyanosis seen, and there can be cardiovascular collapse, and basically death can occur, and it should be avoided in neonates, chloramphenicol, and even if it is given, dose should be 25 milligram per kg per day. Gray baby syndrome, this is the neonate or the premature infant stops feeding, there is vomiting, hypotonic, hypothermic, distended abdomen, irregular respiration, ashen gray cyanosis, cardiovascular collapse, and death. And why Gray-Bobby syndrome occurs in neonates? This is because of the inability of the neonate to metabolize or excrete the chloramphenicol due to deficiency of glucuron transferase. Means glucuronyl conjugation doesn't take place, so chloramphenicol levels in the body gets increased. So there is toxicity of the chloramphenicol leading to cyanosis and other features. At high concentration, it inhibits the electron transport in liver, heart, and skeletal muscle. Avoided by dose reduction. It should be less than 50 milligram per kg per day for the full-term infants, and for the preterm infants, it should be less than 25 milligram per kg per day. Drug interactions, it inhibits the hepatic enzyme, so it increases the levels of phenytoin. So phenytoin toxicity can occur. Tolbutamide hypoglycemia can occur. Bleeding disturbances can occur by the anticoagulant warfarin. And it antagonizes the action of penicillins and aminoglycosides. It antagonizes the action of penicillins and aminoglycosides. Why it is rarely used? Because of its potential toxicity. It can cause bone marrow depression, aplastic anemia, granulocytosis, leukopenia, anemia, thrombocytopenia, nausea, vomiting, diarrhea, and Gray baby syndrome in neonates and infants. It can cause hepatotoxicity. All this results in the potential toxicity, and the bacterial resistance has developed because of the acetyl transferases enzymes and decreased permeability to the chloramphenicol in the bacteria, and there is availability of other effective alternatives. This is ineffective in nature. So availability of other effective alternatives are the reason for why it is really used now. Thank you. That's all for chloramphenicol, and I hope you understood my video. And if you understood my video, kindly subscribe to my YouTube channel. That is Dr. Nitika Hans Pharmacology Discussion. Thank you. Be happy. Be blessed. Happy learning. Stay safe. Stay healthy. Thank you.